go over kind of the background of xylazine in Philly and kind of how we've responded, and talk about overdose and wound care. And then I think we'll just open it up for discussion and questions. I imagine there's things that will come up or that people want to talk about. So that was kind of the vision for this. So just to give you some information on my background, I'm a nurse in Philly. I've always worked in Philly. I've worked with people experiencing homelessness and people who use drugs since 2010. And so I've worked kind of through fentanyl coming and through xylazine. I worked for several years in the shelter system doing outreach, and then worked in a federally qualified health center that saw only people experiencing homelessness. And then for the past 5 years, prior to coming to the Healthcare for the Homeless Council, I worked in permanent supportive housing. And so did a lot of kind of a mix of like street outreach to folks and home visits to people who were in permanent supportive housing. And our patient population at that time was all people with a primary diagnosis of opioid use disorder. That was their diagnosis to come into permanent supportive housing. So lots and lots of folks who were using fentanyl, and then lots and lots of folks who were using fentanyl that was cut with tranq. So that's kind of the background I'm coming from. And I still work on Fridays in a clinic, and we still are, are seeing folks with these types of wounds. So with that, I will dive in. And if people want to put questions in the chat, I'm not going to talk through the slides for too long, and then I think we'll have time to do discussion. Plenty of time, I hope. This is just a little bit of information about Healthcare for the Homeless Council. We have a lot of resources on our website. We provide free training and technical assistance nationwide to people who work in healthcare for the homeless settings. And we are about to have, it's not out yet, but it's coming soon, like a series of quick guides around substance use. So that's something to look out for. We're going to have one on xylazine. They're intended to be like 4-page kind of like brief guides for people who work in any type of service delivery for people experiencing homelessness. And so we're going to cover like K2, spice, meth, xylazine, fentanyl, methadone, alcohol. There might be a couple that I'm missing, but it's a bunch. They're all going to come out together. So we're really excited about those resources coming out. So this is some just background on tranq, and you may have, some of this may be coming through to you all, or you have done some research on it. And so I'm just going to talk through a little bit kind of what we have experienced and know about tranq, which is xylazine. It's an animal tranquilizer. It's an alpha-2 agonist. It's a clonidine analog, meaning it's kind of similar, acts in a similar way to clonidine. In terms of the physical impact on people, it is not approved for use in humans. It's been found in trials to actually be dangerous, and the trials that were done were halted because people were having fatal events. And so they did not continue. It can cause prolonged and profound sedation. It's a muscle relaxant. It can cause, similar to clonidine, hypotension, so low blood pressure, bradycardia, a slowed heart rate. And we know those are things that can happen with fentanyl as well. So this can kind of pile on top of that. So people can have an especially low blood pressure, very, very low heart rates. It doesn't happen for everyone, but some people, it kind of has like an increased impact. There is more and more data coming out that shows that people who are using fentanyl that has xylazine in it have an increased risk of overdose. And some of that is thought to be related to just how sedated people can be. And it's not so much that it's depressing the respiratory center like opioids do. It's more that the person is like so sedated that their airway kind of collapses. It just impacts their airway because of how sedated they are. The other thing we're seeing is that it has some vasoconstriction effects, meaning it can slow blood supply. And we think that that has to do with why the wounds develop. The wounds are still kind of a confusing, unknown situation, but it's thought to be related to those vasoconstriction effects. And I'll talk more about the wounds. So in terms of the clinical presentation, people can have a prolonged period of pretty significant sedation. We are seeing wounds that can be significant, and they are not necessarily associated with injection sites, and they're not associated only with injection use. So people can still have these wounds even if they're smoking, even if they're snorting, and it has xylazine in it. And people in Philly, a lot of people use in their neck, but the wounds almost always show up in the extremities, in the arms and legs, hands and feet. And so it's not like related to the injection site. It could be, but it's not necessarily related. So that's what we've seen. And when this first started in Philly, we didn't know what it was. It was around 2017, 2018 when we really started seeing these wounds. And we really could not figure out what was going on. We thought people were injecting bath salts, which they were, but that wasn't what was causing this. We were just really struggling to try to understand kind of what was happening with these wounds. This is a little background of xylazine in Philly. So xylazine has been present in Puerto Rico since like 2000. It's been there for like almost 20 years, even a little more. And it came from Puerto Rico to Philly, we believe. And we had been seeing it in like 2010, but it really didn't pick up until 2016, 2017. And now in Philly, over 90% of our we really don't have heroin in Philly anymore. It's pretty much pure fentanyl, but what's the drugs that are being tested, over 90% contain xylazine. And the amount that they contain can be hugely varied. Sometimes it's a very small amount. Sometimes it's like predominantly xylazine and just a little bit of fentanyl. So it can really range. The fentanyl xylazine combination is a tough one. People can really be sedated, and the sedation can be different from opioid sedation. So the way I think about it, there's two kind of sedation situations. There's someone who's just really sedated or like really in a heavy nod, and then there's people who are overdosing. So what I see as the difference and what I have seen is like, if someone is really in a heavy nod, you could go up to them and, you're wondering if they're okay and be like, hey, are you okay? And they like pop right up and they're like, I'm fine, I'm totally cool. Or if you're like, concerned about them and you're like, you need Narcan, the person like pops right up and is like, no, I do not. And with xylazine, like people remain sedated. Like you can go up to them and just be like, hey, are you okay? And they like, it's a pretty constant level of sedation. They're not like coming up out of the nod in the same way. So that's what I have seen as the difference in terms of just kind of what it looks like when people are using. The xylazine, there's a lot of talk about like xylazine is giving fentanyl legs because fentanyl, comes on and wears off so quickly. And it's a way to kind of keep people like having to use less often. However, we have heard people coming back and saying they don't want to use xylazine for many, many reasons, but it lasts so much longer than the fentanyl. Sometimes people will come out of their sedation and they're already in withdrawal from fentanyl. And so they have been sedated for long enough that they're like starting to have some withdrawal symptoms, which makes it's just really challenging. There are symptoms related to xylazine withdrawal, which are mostly around anxiety and panic. People just feel like profoundly agitated and uncomfortable and, really, really anxious. And that can last, as we have helped people kind of come off fentanyl with xylazine, like that can last for several weeks where people are just having this like continued anxiety and discomfort that is really difficult to manage. Another thing that I just added actually when I was going over these slides this morning that we started seeing when xylazine came on the scene and we like had no clue what was happening. We saw all these people with wrist drop, like compressive radial neuropathy. So all these people who were coming in and they like couldn't use their wrist. And we actually called the health department and made a report because we were like, we're seeing all these people with wrist drop. We have no idea what's happening. And now looking back, it was because people were so sedated for so long, they like weren't moving for hours and hours, and they were causing like compressive neuropathy. And so they were having like a temporary wrist drop that would last for like, days to weeks. But when it first started, like we had all these people coming into the clinic unable to use their hand. And we were like, what is going on? It was so really concerning. The other thing that to mention is there is a risk for rhabdomyolysis, so like a damage from muscle breakdown that can happen from not moving for such a long time. So sometimes people are sedated for so long, it's as if they like had a fall at home and were like trapped on the floor for a long time. They actually can get rhabdo from being sedated for so long. And then, of course, the wounds, which are a frightening factor for people. They are most often on the back of the forearm, so the dorsal forearm, and people do get them on their hands, legs, and feet, and it's the front of the shins and the feet is where they usually end up coming. So then kind of switching to think a little bit about overdose, what we have seen is the challenge around sedation. So we're a little bit more used to in responding to an overdose, even with fentanyl, having the person kind of like come to, so to speak, and regain consciousness and respirations. And with xylazine, people may start breathing again, but they remain unconscious or like really sedated. And it can be, when you're in that moment of responding, it can be really scary to have the person like stay unconscious. So we heard some really fascinating data from folks who from Pittsburgh Prevention Point. Sorry, my cat is coming through the scene. um, so they have collected data on overdose response, like just programmatic data. And I think they're working on publishing these data in their program out in Pittsburgh. And so they kept data, I think from 2013 to present. And so they have kept data through like fentanyl coming on the scene, and then now with xylazine. And so essentially what their data showed is that when they switched from heroin to fentanyl, they really didn't see an increase in the number of Narcan doses needed to reverse overdoses. It pretty much stayed right around 1.5. Like people need 1 to 2 doses. Even when fentanyl came on the scene, even when fentanyl pretty much replaced their entire heroin supply, the average dose was 1.5. And when they saw these like outsized number of doses being given, there was usually an explanation, like it was a new responder, it was someone who was like an unfamiliar responder, or someone who came on the scene and like didn't know how long the person had been down for. So what they're now seeing in the past like 2 years as xylazine has come on the scene is that they, for the first time now, are seeing a spike in the number of doses needed. And they're thinking, or doses given, prior to deciding like the overdose event is over. So they are thinking this has to do with xylazine. They don't know that, but this is the thing that has changed and people are just remaining sedated. So the thing to think about with that, obviously, is that, we don't want people to go into a severe precipitated withdrawal. We do not want to give more Narcan than needed. And so we really need to do some education in the community about what this might look like. And I was just talking to a nurse the other day on our the Project Home Street Med team, and she said, I really cannot emphasize enough how different this looks, having reversed multiple overdoses. Like when someone has a lot of xylazine on board, it's really frightening and it's way, way different. And the person just remains like completely unresponsive sometimes, even though they start to breathe. So the advice we give is to really look for respirations and to get the person in a recovery position, because they're likely to remain sedated. I think we recommend calling paramedics if the person is remaining sedated. Sometimes people do not want to do that. And then the thing to think about is if the person is breathing and they seem okay, but they are completely unconscious, and someone does not want to call paramedics and they're going to stay with them, to make sure the person is in recovery position, but that they're shifting them, like essentially like what you would do for someone who's bedbound because of rhabdo and because of pressure sores, because people can stay that way, sedated for quite some time. Although typically we try to call paramedics to have someone be further evaluated. So that's the kind of education that we're trying to give in the community. And we did here in Philly in 2018 also see a huge spike, just anecdotally. I have not seen data from Philly of the number of doses of Narcan needed to reverse people. And we're just hearing people say like, oh man, I hit this guy with like 5 doses. It took 7 doses for this person to come back around. And, it really wasn't that they needed that much. We don't think now in retrospect. It was just that they were severely sedated from xylazine and they were just getting all these doses. I see someone asking how slow or how long between breaths. So we usually use 10 breaths per minute as our level here of kind of being like, this person is breathing enough. Obviously, if you have the ability to check with a pulse oximeter and see what their oxygen level is, and if the person is breathing 10 times, but they still have like, bluish tinged lips, or their breathing sounds like agonal, like it's just not like, it's like gaspy, not normal breathing, then I wouldn't, that's not enough. But if the person is breathing comfortably and they're breathing at least 10 times a minute, that's usually around the cutoff we use, but like thinking about all the other signs that are happening for them as well, and whatever vital signs you can get. The other thing we warn people about here in Philly, I don't know for you all, but a lot of people here in Philly who are on methadone, they are subject to drug testing. And so they often use clonidine as a additional sedative because it's not tested. It's a prescribed medication, but you can obtain it on the street, and people use it to kind of like augment their high for the other stuff that they may be using, but they don't want a lot of stuff to show up in their urine. So we caution people to be careful with using clonidine. If they're using fentanyl that is likely cut with xylazine, it can just kind of compound that effect of the hypotension, like low blood pressure and slow heart rate. So for people who are using clonidine, we just like give a warning to really be cautious with that, and we do not recommend combining them. And then I talked a little bit about the overdose response and how to support people. So you want to, I have some resources at the end that has some more information about how to respond. Prevention Point in Philly, which is our syringe service program, they have done a lot of work around responding to xylazine overdose. Another tip, which I don't think I have elsewhere in here, for people who are sedated on xylazine that they have developed, is to just splash a little bit of cold water on the person, either on their, like, not on their face if they're not breathing. Obviously, you don't want it to get in their airway, but a little bit on their forehead or a little bit on their neck to kind of like get them to be alert. And that has actually worked really well for them. They like poke a hole in a water bottle, so it's like a very small stream of water, and we'll just kind of like say, after saying to the person, are you okay, and trying to rouse them, if they don't get up, they do a little spray of cold water, and a lot of times the person, they do kind of wake up with that. So that's another way that they have used to assess if someone needs like the type of support they need, if they need medical help, or if they just kind of need to come out of being really sedated. And I think I put that resource at the end. So I'll share these slides and you all can do whatever you want with these slides.
Sorry to interrupt, Kate.
Yeah,
Kimmy,
go ahead.
It looks like you had a question. Did you ask your question, Kimmy? No, do you still have a question?
No, I do have a question.
Go
Thank you.
ahead. Yeah.
Kate, this is really good information. However, the one thing I'm hearing is to watch for the breaths. Are we still
Mhm.
only trying to use the 1.5 doses of Narcan with somebody on the xylazine due to we don't I mean it's usually one extreme or the other, right? Either they're too far gone and then we put them into too far of withdrawal. So I know up here in the South King County area, people are saying like 2 to 3 doses, sometimes even 4, and I'm like, that seems a little overzealous knowing what I know coming from my background. So what are you guys recommending medically?
So we try to really follow the suggestion of like giving a dose and like actually waiting a minute to see how the person responds. And then if it seems like they're not responding at all respiratory wise. And so we really, because of xylazine, are kind of separating like I know people have this idea of Narcan where you like give it and the person like pops up, and we know that it's not really like that, but people remain even more sedated. And so we really just try to look for respiratory response as the primary driver of like, do they need another dose? And if we give one dose and the person starts to breathe, and they are still out, like they may only need one dose. And, as a standard practice, we would still call paramedics in that situation to assess and see is something else going on. But, the xylazine is not going to be touched by the Narcan. You're just going to kind of keep like
Right.
You
That's
can
kind of
cause
our
a pretty
problem here.
severe, yeah, like
Yeah.
precipitated withdrawal. And we had the same, I mean, the same thing happened in Philly. We didn't know what was happening, and we were just giving people so much Narcan, thinking it was the fentanyl, and just thinking like, the fact that our whole supply is fentanyl now means we need, 5 doses to reverse someone. But now that things have kind of leveled out, we're seeing that that isn't really the case. We just have to kind of approach it a little different.
Thank you.
Mhm.
Great question. Thank you so much for asking that, Kimmy. And then it looks like there's one more from Cassie as well.
Yeah, hi, good morning. I just had a question regarding if there's any difference between injectable versus the nasal, or if you're seeing any quicker response time or anything like that between the two variations.
I don't think we have. I mean, I think in general, the injectable does work faster. We almost exclusively use the nasal Narcan, and so that's pretty much what is available in Philly. That's what people carry, and that's what is being used. So, thinking about like the number of doses needed, in my mind, I'm almost always thinking of the nasal because that's what people tend to carry.
Okay, got you. Yeah, I know. Yeah, in King County, we are seeing like a shortage of nasal Narcan.
Oh,
So we
interesting.
have, yeah, like I've staffed up my team to be able to provide injectable, but yeah, I was just wondering if there were, differences between the two. So thank you for the clarification.
So in terms of how to help people with the withdrawal management, there is a withdrawal syndrome. As I mentioned, people get like very uncomfortably irritable, anxious, panic, like mood changes. People can have, because it's similar to clonidine, some like rebound, high blood pressure, and increased heart rate. A lot of times if people are in an inpatient setting now here in Philly, and we know they have had Xylazine on board, they will have cardiac monitoring for that reason. But in the outpatient setting, it's really just a matter of trying to support people. And I linked here a health alert that was put out by the Philadelphia Health Department that has some information on the meds that people are using. Some of these are inpatient meds only, but some of them, like tizanidine, clonidine, the gabapentin, benzos, can be used in outpatient. And we have some providers who have tried to use those to kind of help people to come off of Xylazine if they're trying to stop. It's really hard for people who are trying to transition, let's say, onto buprenorphine. They're dealing with the fentanyl issue, but then there's also what's happening with Xylazine because they've been using both. And so there's like this anxiety component that kind of has to be managed as people are trying to switch over. So that has been challenging. And then in an inpatient setting, now there's more awareness about it, but when it was new, we had people having a really hard time staying in the hospital, even if they were getting support for opioid withdrawal. Like the Xylazine withdrawal was so uncomfortable, they couldn't tolerate the hospitalization. And so there was a component of we're having to like educate and kind of say to the providers in the hospital, like, hey, I'm concerned that they may have been using stuff that was cut with tranq. And so they might be having some withdrawal from that, just to even know it's like new to everybody. One of the resources I put in here at the end is a PowerPoint presentation from Jefferson Hospital here in Philly about inpatient management of people who are withdrawing from fentanyl and Xylazine, because they're seeing it so much in the hospital now. They really have to address both. And they do, clonidine in the hospital. Obviously, they're very careful around heart rate issues with giving clonidine. And so they just usually do in an inpatient setting, it's much easier to do cardiac monitoring for people. Oh, sorry, I should have warned you about this. Here comes some wound pictures. Sorry, didn't mean to scare you with that. So the wounds are a very, I know, frightening component of the Xylazine use, and they're hugely problematic. And so I wanted to share some information about kind of what they look like when they start, because similarly in Philly to perhaps how you all are feeling now, like we just didn't know what we were looking at. We didn't know why these wounds were happening or what was going on, but we were seeing all these people with these, sometimes really, really terrible wounds. So this is kind of what they look like when they start at presentation. They're often circular. They're like an erosion, they're full thickness. They go all the way through and oftentimes have a wound base that's like pretty thick, like yellow to black eschar. Like just a lot of times when they first start, it's just yellow and it's like a hole in the skin and it goes pretty deep. They're often very quite circular. And then over time, if they continue to worsen, they just all merge together into like a huge wound. But they often start even as just a single, like on this picture of the person's hand, they have like a little single. So we have seen once we kind of knew what it was, like sometimes when folks have the beginning of these wounds, if you do treatment for the wound immediately, um, they would resolve. And the person might have kind of continual wounds, like there's one on one hand, then there's one on the other, then they have one on their ankle, but they all kind of stay small. And with treatment, they don't necessarily merge into something larger. So there's something to be said for addressing them quickly. And people have a lot of shame about them. There's a lot of fear. And so they don't want to show the wounds and don't want to bring them up. But as much as we can, I think, educate people that this is a possibility. And if you see this type of wound starting, like come to someone immediately to get some type of care so that it doesn't get worse. The next picture is worse. This is kind of what they can progress to. So this largest picture of the person in the hospital gown, this is like, to me, like the classic presentation of the xylazine wounds. There's all this black eschar. They're almost always on the dorsal forearm like this. They can take up the whole space from the elbow to the wrist. They can go very, very deep. There's often tendon involvement. There can be bone infection if they go for a long time. And people really, they're scared to show them. They're quite frightening looking. And so sometimes they get very, very severe before people come in with them. But I will say, we also are healing these wounds in Philly. We have some people who have had to have a limb amputated as a result of these wounds. And we have a lot of people who we have helped who have been able to resolve them and they completely close. So I think, let me go to my next phase. Oh yeah. So this is just kind of what the wounds look like. They're very large. They have a necrotic wound base. The telltale sign is that like black eschar, all that black, like very thick, dry. There can be a lot of exudate. We often say, they can look really, really bad. It doesn't always mean that they need antibiotics, even if they're looking really frightening. We want to look for signs that someone is having a systemic infection or there's like cellulitis or wound, spreading around the wound. Just because the wound looks bad doesn't necessarily mean they need antibiotics. We have found that just doing consistent wound care is like the majority of the battle. It's when the wounds are left untreated that people have like a significant worsening and end up with an amputation. And we have really tried to do a lot of education for people and try to help people to manage their own wounds as much, obviously with support, but people can't come in every single day. And so it really makes a difference to have a regimen that someone can do on their own. So this is the kind of basics that we provide. And I want to say I am not a wound specialist. Have worked with a lot of xylazine wounds. We on our team at Project Home have a certified wound ostomy nurse who's a nurse practitioner who works with us, and she is an invaluable resource to us in kind of figuring out how to address these wounds. The other thing we have seen in Philly, as lots of people have had these wounds, and we've had a lot of people trying to help. People are ending up having worsening of their wounds because they're just being handed wound care supplies without an assessment. They're being handed supplies without really knowing what, there's maybe specialty dressings and they're not appropriate for the wound. And so people are actually having some worsening of their wounds because they're being given supplies that aren't necessarily the right thing. They're not getting a lot of education around how to manage them themselves. And they don't really have someone necessarily following the wound. So a lot of times this type of outreach is very important, but when it's happening outside and the person isn't comfortable showing their wound, which is totally understandable. Like sometimes the wounds are essentially being treated like sight unseen, like no one is looking at them and only the person knows what's happening, and they can really get worse fast. So this is like the basic care that we share with people. And this is like really the majority of the battle. Like you want to get it as early as possible. A lot of people use very harsh cleansers thinking that that's going to kind of get rid of the bacteria that's in there. And so we have people putting bleach in there, peroxide, like pouring rubbing alcohol in. And so we're always saying, like, please don't put anything harsh in there. You know, just use a saline wound cleanser. You can cleanse with mild soap and clean water if that's all you have. It's hard for people sometimes not to pick at the wounds, but obviously we don't want them doing that. We have found a lot of people inject into the wounds, partly because they are in a space where they like have really nowhere else to go. You know, their veins are really difficult. They also have a lot of pain in the wounds. And so that makes people want to inject directly into them. And it might be kind of like the only space they have, and they're scared of getting a wound, let's say on the other arm. And so they keep kind of injecting into the place that's already not doing well. We use non-adherent dressings. You know, there obviously are other dressings people use. Sometimes people use like a Xeroform, like a petrolatum dressing. Just the regular non-adherents are work also. And we feel comfortable like giving those to people. And then we do recommend just using the specialty dressings only if someone has assessed the wound and has been able to say like this is an appropriate dressing. And if people can clean and change daily, that's obviously best. Sometimes that's not possible. So we always try to refer people into primary care if they're not connected. Obviously into behavioral health care and treatment if they're interested, and then to specialty wound care or to the hospital if it seems like they need a hospitalization. And, you know, the thing we're trying to do with these wounds is to get that, the eschar off, kind of debride that necrotic tissue. Sometimes a surgical debridement is kind of the only way, especially if it's really, really significant. But we have had success with just using like wound care products and dressings to also kind of remove the majority of that soft tissue. Measuring the wounds and documenting the progress has been hugely helpful. You know, it's, as you may know, it's really hard to look at a wound and tell like this wound is bigger or smaller. And we have found it's really encouraging to the patients if we have measured it and we say like, oh, this is a half a centimeter smaller. And that's hugely motivating to people. They feel like they're like making progress. They want to keep doing it. They're like so happy. And it actually makes a difference too to have the before and after pictures. So if we take a picture in the beginning and then show them like 3 weeks later, like, hey, this is what it looked like, and now look how good it's looking, people are always very, very excited to see that change. I know you guys talked about a lot of the press that's happening is like very catastrophic sounding. You know, there's all these threats of amputation, and people end up feeling very hopeless and then don't want to address the wounds at all. They just feel like they're only going to be told you're going to lose that arm. And they just are kind of like, it feels like it's inevitable. And so we really, really try to message to people like, it is not inevitable. You know, wound care is being done on these wounds and they are healing. Sometimes you do need a short-term hospitalization if you need the surgical debridement, but it doesn't mean you're going to lose your arm. And so we really try to kind of back away from that, you know, of just saying to people like, oh, you're going to lose your arm or like your leg is, you know, going to be cut off, because that is not motivating to people at all. We do a lot of work to prepare people for what it will be like in the emergency room or hospital around withdrawal management, around what they might face in terms of stigma, just so that they're prepared. And we have done a lot of kind of connection work with the hospital so that they know the outreach teams to be able to say, like, this person's coming in, we're supporting them, and having some dialogue around their needs. And then we think a lot about the dressings and patient goals and how they use substances. So we found early on, or we discovered that we didn't know people were injecting into the wounds. And so we were putting these like super fancy dressings on and like wrapping it all up for them. And then like an hour later when they needed to use, they like took off the entire dressing and it like never went back on again. And so the wounds were remaining uncovered. So we actually started using like a stretch net gauze over the dressing so that it could, and just a simple like non-adherent with a little bit of like conforming gauze wrapped around it so that people could just pull back the dressing, use if they needed to, and like put the dressing back in place very easily. And it made a huge difference to keeping the wounds covered, because really we were essentially doing wound care for them to be covered for like an hour. And then they were uncovered for the next week until they saw us again. So giving people supplies that were super simple to use, that they could keep in place for several days, and that they could kind of manage on their own, made a big difference. And just finding out from people like, you know, are you injecting into the wound? And if they are, then we could make a dressing that made sense for that. I saw someone asking the reason for injecting. So sometimes it's because, yeah, it's really painful. They want to inject to try to numb the pain. Sometimes they have no other site to go to, or they feel scared of another wound developing. And so they don't want to like use their other arm or anywhere else. They just keep using the arm that's already been affected. This is just a little, this was made by the Philadelphia Department of Public Health. It's a little info sheet on Trank. And then these are some additional resources that I think would be helpful. So that's all. And this is my email. You're welcome to email me if you have questions. And then I'll, if I can, let's see, I'll stop this share, and then we can, if folks have any questions, I'm happy to answer them.
Thank you so much, Kate. And I know I'm speaking on behalf of all of us here when we say that this is so helpful and so timely for conversations happening around our community. I learned so much from this. It looks like we just, Michelle, I think that you have your hand raised. Is that right, Michelle?
Yeah, thanks. Thank you
Yeah.
so much, Kate. Thank you so much for what you're doing. I mean, I'm just moved like emotionally around how you're navigating and how you're loving people, and so grateful for you and your team. So thank you, and thanks for sharing with us. I have a question about just trends that you're seeing in terms of fentanyl use. And I mean, a lot of folks moved, what we're seeing is a lot of our folks have moved away from injecting, and we're seeing a lot more smoking of pills and powder. And I'm curious if with Xylazine, and I had heard some things that, you know, you can smoke it, but it's typically injected. I'm curious, what is the most typical route of use that y'all are seeing? Did you kind of see an uptick in Xylazine once it got on the scene in 2017? What would we kind of want to prepare for in terms of manner of use?
I think Philly, perhaps more than places on the West Coast, just from what I have heard, is Philly is very injection based. Like people who use inject. People inject meth, they inject coke, they inject bath salts, they inject fentanyl, xylazine. Nobody really, there are not a lot of people who smoke or use other means of use. And I think that's just kind of a Philly thing. So we already had people who were mostly injecting fentanyl at the time that xylazine kind of came on. And so that has continued. People mostly continue to inject. I have not seen a big shift. You know, there are some patients I've had who never injected. They felt very strongly about that, and they have not, you know, they have continued to not inject. But I would say the vast majority of people I have worked with, which is, you know, hundreds of people, all inject. That's just kind of the Philly way. Everything's getting mixed up and injected.
Yeah, Kate, I will hop on. I have a question. Or I mean, honestly, for the larger group as well. This is something that came up for us this week. We have a client who is a fentanyl user and he routinely smokes. But we did like a full room sweep, and when we were in there, we found, and I was with my coworker who used to work in the ER as a med tech, so like I trust his experience. Like he's definitely seen these things more than I have. And we were in there and we saw like little tubes of compressed air that had been sharpened down to a needle point. And this client, again, is a regular fentanyl smoker, but has just sores everywhere. And so, my coworker was like, I think he's injecting and bolusing himself. So I'm curious to know, like, if anybody else has had that experience. I can only imagine how incredibly dangerous that is. So I don't know if anybody else has experienced that or what that looks like in terms of a high, but I'd be really interested for perspective on that.
I'll let other people jump in. I'm not familiar with that at all. We definitely have people who like can't get a vein anymore, and so they just use sub-Q, but they are using syringes. I've not seen anybody using anything else.
Yeah, I mean, I've dealt with hundreds of clients, especially hundreds of SUD clients, and I'd never seen anything quite like it. But I mean, he definitely had, sores to the point of which they look like in some of those pictures for sure. And so I have no doubt in my mind that that's what his fentanyl is being cut with for sure. But yeah, I mean, upon like further investigation, like, and knowing that he is a smoker for sure is just, again, I'd never even seen the compressed air tubes, but they were filed down so tightly to a needle point that, I mean, we were all thrown for a loop on it. So yeah. And this is an 18-year-old kid. And so it's just even more devastating.
Yeah, Cassie, I haven't heard of that either, but that is really interesting. And I would be curious, maybe folks who aren't on the call too, since this is going to be recorded, I'll see if I get any feedback on that question, and I'd be happy to do some investigation with you. That's really interesting.
Thanks. Yeah. I don't know. And again, like that's our assumption based off of like what was present, what was presented to us, and like his physical state. But again, I don't have like complete confirmation, but that is what we are very strongly under the impression of. So yeah, I mean, more feedback and we'll keep an eye out for it, but I guess maybe something to keep an eye out. So
yeah, this is a good space to put those questions out, and we can all be in touch if we hear anything more.
I'm just thinking a little more about the kind of trends that we have seen in Philly, and we'll just add like I don't know what it's like for you all with fentanyl out there, but we don't really have any heroin anymore in Philadelphia. In the analysis, it's not even in the top 5 substances that are found in people with a fatal overdose, and so we have almost a pure fentanyl supply. So that that has really changed, obviously, what it's like to use in Philly.
Yeah, that's similar here too. I think over these last 2 years, people are really struggling to find just pure heroin. Yeah. K-Dubs, looks like you got a question.
Yeah. I watched a webinar yesterday that was specifically about xylazine and wounds, and I just want to make sure I'm understanding correctly. It sounded like the wounds can occur like not at the injection site, but they can occur even if somebody just smokes it? Like
that's been our experience, yes.
That's okay. That's what I just wanted to confirm that. Thank you so much.
Alan?
Oh, it's Allie. Hi,
Oh,
Molly.
sorry. Sorry,
Okay.
I read that as. Oh, wait. I think that Allie. I think that there's also an Alan on this call who had a question too.
Oh,
sorry.
funny. Okay, should I go?
You go, and then Alan, if you
Okay.
still have a question afterward, Alan and
Okay.
Allie.
2 quick questions, and I apologize if you covered this. I was sort of in and out. Are there test strips for xylazine that are available yet, like there are for fentanyl?
I don't believe there are any that are commercially available right now, but when I was at the Harm Reduction Coalition conference in October, and they had, I don't remember which of the strip makers it was, they said it was xylazine strips were in development by them.
We actually have some.
Oh, you do?
But they're not official. They're not like
interesting.
CLIA waived.
Okay.
We have some at King County Public Health.
And are they
on
like commercial strips that you bought?
yeah, they look like the fentanyl test strips,
Oh,
but
nice. So maybe those are the ones they were talking about were coming.
yeah. So we didn't purchase a lot because I'm new to King County. I come from Thurston County, and I've seen, to my knowledge, I'm like 2 weeks into this job, as a harm reduction associate, and so I'm still learning about King County. It's like way different than Thurston County in terms of like size and population, and like South King County versus just all of it. So I'm still learning, but to my knowledge, we haven't seen a lot of xylazine, according to my coworkers and people that I've talked to. But I also do the mobile needle exchange in Thurston County, which is AEHOP. So I have a really good rapport with the drug users down there, and there's like no xylazine down there. Um, what the fuck was what was my question? First, my sweetie says hi, Kate. Their name's Taryn. But
Oh, hi, Taryn.
yeah, they're over there. But they're oh, well, that's what I was gonna say. So if people are using xylazine with fentanyl, right? I just want to make sure I understood this correctly. So if they're using xylazine with fentanyl, and you use naloxone on the person who's using are mixing the two drugs, it would be still hard to notice if the person has come out of withdrawal of the fentanyl because they're still using xylazine. It's the same because they're still like using xylazine at that high of rate. So like, how would you like? Are we still capping the amount? Because in Thurston County, there's been cases where it's been needed like 6 doses of naloxone to reverse an overdose of fentanyl. So like where do we cap the amount of naloxone in your, you know?
Yeah. I mean, I don't think we don't really have a cap, but
Yeah.
we really just look at the respirations as opposed, and obviously, the global picture of what's happening with the person, but we're really looking for return of respiration with using the Narcan. And it's true with the xylazine that sometimes people will start breathing again, but they remain sedated. And so they,
Okay.
as long as they're breathing again, they really don't need more Narcan. The opioid portion has been reversed and they perhaps are still sedated from the xylazine. But they probably don't need more Narcan if they have started breathing again and they're breathing, sufficiently and normally.
Okay. And now I actually do remember my question. So I'm also like really fascinated by like the geography of drug use. And so knowing that Philadelphia has this like huge xylazine drug use right now. And also I've learned a lot like Baltimore. Xylazine is like really prominent in Baltimore from what I'm aware of. And seeing that there's not a lot of xylazine in on most of the West Coast, it's like I'm kind of asking everyone because I'm, like a 12-year-old and I'm like just trying to learn like what's up. Like how long do we think like, or, eventually xylazine is going to get its way to the West Coast and it's going to come into King County, it's going to come into Washington. Like, so, I'm very grateful for this presentation because I learned a lot and Kate really like does awesome presentation. I learned so much, but, in preparation of xylazine, knowing all this information, getting the test strips and getting all this, like, is it just a waiting game for us to prepare for when xylazine gets here? Is that like what this is for, or is this, what are we thinking here collectively as a roundtable to prepare for when xylazine gets here? Like, what's our strategic, collective plan? Is that like an okay question to ask?
That's a perfect question to ask for this space specifically. First off, Alan, welcome. I'm so happy that you are joining the county in this capacity. It sounds like you have some really great experience to add. And yeah, I think that, and I saw in somebody just said, Kimmy, you just said in the chat, having more roundtables is amazing. And the last couple of roundtables, we've just been, kind of casually talking about xylazine here and there. And is it here? Is it not? I responded to an overdose where someone was really sedated. Was it xylazine? So definitely, I think my hope for this space is that we continue to utilize it as things come into the supply and talk about it and support each other, especially with resource sharing. Like you said, Alan, Kate, we are so grateful for this presentation and all the resources that you've passed along, and all the work that's come out of Philly. I'm sorry that you all had to, as we say in public health, build the plane while it was already flying. But you've laid the groundwork for a lot of the questions I think that we are having over here in the county. Yeah. I don't know if you have any more answers to the, Alan, you asked a lot of great questions, but just for that last question, I think that we should definitely continue to utilize this space for support for that.
Would it be okay if I talk for a second about some drug checking stuff? So
Please, yes.
Hey Jasmine, one sec, I'm on a call. So I have been a part of the UW ADAI group that is implementing drug checking in Washington State. So there are a few sites across Washington State that have FTIR machines, and we are also doing GCMS through the UNC crime lab. So I would just love to say that like drug checking will be a huge thing that will be helpful. I want to assure people like drug checking is happening. Sites are being very low key about it because of the legality of it. It is still illegal to be doing it. So I won't expose the other sites that are doing it, but I would love to share. I do drug checking at the Downtown Needle Exchange on Thursdays, and I also have Xylazine test strips that I'm able to use with clients. So yeah.
Yeah, and our patients love it. Our patients are so happy, Georgia.
Please, like, be a little low key about it. Don't be like making posters and putting it up everywhere. But if you know clients, especially if someone suspects there's xylazine, someone overdoses on something, I would love to collect as many samples as possible. But we've only been doing it for a couple months, so it's kind of slow rollout. But also just to talk about like the real presence of xylazine. Out of the entire Washington State groups that are doing it, one group has had trace amounts of xylazine in one sample, and that was outside of King County, and they have a very different drug supply. There's where they're situated. It's mostly coming up through Texas. So Washington sites or Seattle sites, we haven't seen any xylazine. Just the ME's reports with very, very few overdoses last year where it was detected. So that's a little bit of context that I've been learning.
Yes. Georgia, thank you so much for that. That is really, really, really helpful. And Kimmy also says that Pure Seattle and Pure Kent both have vending machines with testing strips too. So, man, this is a lot of really rich resource sharing. Georgia, I had no idea that that was going on, and I'm so excited to hear about that resource, and I would love to connect a little bit further to get some more information about that with you. So thank you.
I can put my email. I'll put my email in the message thing, and if you have questions about drug checking, stuff like those services, I'd be happy to talk to people.
Drug testing is like the coolest thing ever, just for the record. I just want to say that.
Yeah.
Everybody. Yeah. I'm gonna
Yeah.
reach out to folks. It's the coolest thing ever.
Yeah, I'm like starstruck that we get folks who do that on this call. So thank you so much. I know that some folks have to hop off. If people, I can stay on for the next 5 to 10 minutes if people want to continue asking questions, and I can, collect those. I'm sorry, my cat is in a conversation with the dog right outside the window. And so for those of you who have to go, thank you so much for joining. I will also be sending the follow-up email with the recording. Next month, I am really excited about our topic. We're going to have Michael Light, the social worker for the outreach palliative team, lead a conversation on the overlap between the philosophies of palliative care and harm reduction, which is also another kind of philosophical topic that we've touched on a lot. So I'm really, really looking forward to that conversation, especially in light of what's happening with xylazine and fentanyl. I think that this will be a really continued rich conversation on that. So be on the lookout for emails on that. Yeah, and if people still, Kate, I don't know when you have to go, but I'm happy to stay on for like 5 more minutes if people have burning questions.
I can too. If people have other
Awesome.
questions,
Thank
I can.
you. Okay, I think that there was, let's see. Yeah, Chaz. Okay. Somebody else had said, oh, Ali had asked, wondering if you guys are seeing folks intentionally wanting to use xylazine.
We not very much. I think what we saw initially was people didn't necessarily realize at first they were using tranq, and then when they did, the withdrawal was uncomfortable enough that they continued to seek out people who, people they knew were selling fentanyl that was cut with tranq because they felt like they needed to continue it. I don't know of many people who intentionally sought it out, really any. The folks I'm thinking of are people who the withdrawal syndrome, once they had started it kind of unknowingly, was so uncomfortable they continued. But in Philly, similarly, there was a lot of fear around once we kind of figured out what was happening, that it was causing such severe sedation and the wounds, people were really wanting to avoid it for the most part. And now we're in a situation where, similar to fentanyl, like, we were testing for fentanyl until everything was fentanyl. And now, pretty much all our fentanyl is cut with xylazine. And the quantity is the question, and we don't really have a way easily yet to like quantify like how much is in the supply, like in a particular source. Like we don't know if it is like half xylazine or, a tenth xylazine. So that has been challenging, but no, I do not know a lot of people who sought it out. Certainly not initially. Now people do because of the withdrawal. They just, it's really challenging.
That's super helpful. Thank you. Good question, Ali, also. And Cassie's asking, will the slides be sent out? Are you happy to
Yes,
share
I can
those?
send them.
Thank you. Awesome. Yeah, if you send those my way, I can include that in an email with this recording, and I'll include a few other things like Georgia, if you don't mind if I put your email right there in the body of that for folks to use. There's been so many great resources that have come out of this conversation. Yeah. Awesome. All right. Any last minute things before we sign off for this beautiful day?
I just want to meet you, Alan, by the way.
Oh, yeah.
I'm just a little bit excited.
Let's do it. I love meeting
Okay.
people. I like to make friends. I don't have like friends, so it's like, any opportunity.
Okay, I'm gonna reach out to you.
Yeah. Do you need my email or?
Yeah, you're on Teams, right?
Yeah, I'm on Teams.
Cool. I'll just do it shortly. And I just want to say, Kate, thank you so much. You guys are amazing. And I have been attending quite a few xylazine things, which I think you've been on and also talked on those two. And you guys just blow me away. So I just want to thank you so much for everything.
Kate, that was like such an awesome presentation. I would love the slides because
I'll definitely send them out.
Aggie Hop down in Thurston County, like it was just like last week what brought up xylazine stuff, and I was like the only person that knew anything about xylazine, and I know nothing about xylazine. So like being able to share this information with the county that has like no info about it would be incredible. So if I can get those slides, the information getting spread out across Washington State would be incredible. So thank you so much.
Yeah. Definitely.
So happy I was able to make it. Ellie was able to invite me this week, and I'm so happy I was able to make it because I had not a lot to do today. So,
and I'll share with Molly. There's a few other things coming up if you're kind of interested in continuing to learn more. We are planning a webinar with Homeless and Housing Resource Center for July that's going to be on xylazine, and we're hoping to have a few folks from Philly on the call, including some patients who have had experiences with xylazine. We're hoping we can have some people kind of talk about their own personal experience on that webinar. So I'll send that information to you, Molly, when I get it.
Great.
And we
Thank
also
you.
have all of the resources coming out, all the like little quick guides, and one of them is for xylazine. So once those are available, I'll send that to you too, Molly, and you can pass it along.
Perfect. Thank you. Thank you so, so much. Yay.
You're welcome. I'm sorry that we have to share this information, that it's happening, but I'm also happy to be able to share what we know, because I know it's tough when you know, people are struggling so much and you like just don't even know why or what's happening, and it can be really frightening. So
Yeah, thank you. I appreciate that sentiment. We talk a lot in our world, as you all I'm sure do too. We're like, this is so wild that we all need to be hired even in this field. Like what is happening? And yet there's so much beauty in raw humanity. And I think that the thing that at least gives me a lot of hope is the sharing of resources and the connections that we make along the way, to support each other and support the people that we're serving each day. So thank you for providing some of that hope today and taking an hour out of your day, to do this.
yeah, you're welcome. It was great to be with all of you.
Yeah,
I'm so glad you all have this community. This is wonderful.
Thank you. And good luck with the bed bug scare.
Thank you. You know,
Yeah.
we just take it in stride. It's no big thing.
Right. Nothing we haven't seen before, you know?
Yeah.
We can it just takes time, that's all.
That's right.
All right. Well,
Okay.
thank
Thank
you
you all.
so
Thank you so
much.
much.
Have a
Thank
lovely
you.
Have a
week,
good rest of your day.
everybody.
Yeah.
Take care. Bye.
Bye.
Bye-bye.